It is my pleasure to interview today Dr. Anastasia Kirillova. She holds PhD in embryology from the University of Vienna in Austria and currently works as a laboratory manager at the Royal Women's Hospital in Melbourne, Australia. Anastasia co-authored publications in such prestigious journals as PNAS and Development. Her pioneering research on the application of in vitro maturation technology for oocytes obtained from ovarian tissues in patients with ovarian cancers was selected for prize session presentation at ASRM. Anastasia is frequent speaker at international conferences, so she is a world expert on in vitro maturation of human oocytes. Dr. Kirillova, Anastasia, thank you very much for accepting my invitation for this interview.
Thank you, Dmitry. It's really my pleasure to be here and to speak with you.
How you became interested in vitro maturation?
So I started practicing IVM probably around 8 years ago. So first I received the training in ovarian tissue cryopreservation for fertility preservation. And it was always my passion to help patients who were diagnosed with cancer and who are faced with a high risk of losing fertility, because I know that it's very important for women to have choices, to have an opportunity to realize their reproductive function. And unfortunately, some patients are forced with this diagnosis and then they have no choice or they don't have the options. So that's when I first thought that it would be great to offer them ovarian tissue cryopreservation programs. So I studied this technology in Denmark. I received the training, and then I came back. At that time, I worked back in Moscow. So we started this procedure of ovarian tissue cryopreservation. But what I noticed was that while we cryopreserve the cortical tissue, where all the primordial and primary follicles are located, we discard medulla. And that's the technology, how it works, and it's done worldwide. But at the same time, the medulla is a source of plenty immature eggs from antral follicles, and these immature eggs at the GGV stage are just discarded. And at that point, I started thinking how we can boost the opportunities for women and how we can use these eggs for the clinical use. And then we started trying in vitro maturation. So we kept isolated these eggs and then matured in vitro. And then we actually obtained mature eggs even from patients with ovarian malignancies. And after that, we just started using in vitro maturation for fertility preservation. And while the program grew, then the indications also started to expand in our center. And then we tried for women with PCOS, with resistant ovaries, and further on, even we expanded the indications for that.
Now, how did you expand the indications?
So basically, IVM is used for women for whom control ovarian stimulation is not an option, and it can be such a broad variety of different cases. For example, a patient might have the kidney transplant in the past, or they might have like really severe endometriosis, which would also go into even their diaphragm, and then stimulation might be risky to them. Or they might have several failed cases of IVF. And of course, it's not like the classical indication for IVM. But if it's a choice just to stop trying and stop providing them treatment, or to try something else, then maybe trying something else and given an option of IVM might be a good solution for them.
What was special about your research in this kind of patients, which became a point of attention of SRM? Why do you think it was chosen for a prize session presentation?
Firstly, the cohort of patients was really unique because not many labs and not many centers work with women who are diagnosed with gynecological cancer and especially ovarian cancer. So basically, these patients don't have any methods of fertility preservation or treatment which can be offered to them in the routine way. We can't offer them egg retrieval because there is a risk of malignant cell spillage. Then we cannot offer them ovarian tissue cryopreservation, again, because there might be malignant cells in the tissue. So basically, these women just go through radical ovarectomies, they lose their ovaries, and then they have zero chance of having their biological children. So what we did, we took these ovaries and then we isolated eggs from this ovaries. And I just want to stress that it's not normal, beautiful ovaries. Sometimes they are very huge, sometimes they are very deformed by malignant cells. And very often we couldn't even tell where is the healthy tissue. We just have to patiently dissect these ovaries and find the healthy tissue and find potential follicles. So this cohort of patients was very unique, and we had the privilege of having access to many of such cases. We had more than 100 patients who went through this technology and who were diagnosed with gynecological cancer. So I think our experience was unique. And frankly speaking, when we started, we also didn't know how successful could it be. We didn't know if we can retrieve any eggs from patients with malignant ovaries, which are really deformed, which are really enlarged in size. But we found out that we can actually retrieve eggs from such ovaries, that even from stage 4 ovarian cancer, stage 3 ovarian cancer, there is still hope. And so we had this opportunity to work with these patients, and then we got an ethical approval also to do it clinically, which was also unique. So half of these eggs were vitrified for future use, while half of these patients actually had partners, or they just chose to use donor sperm. So we had an opportunity to fertilize these eggs and then culture them till blastocyst stage. And it was also unique because classically, in many labs, IVM goes through just day 3 culture and then day 3 vitrification and day 3 embryo transfer, while we were the first who published that it's actually possible to obtain blastocysts from these immature eggs. And when I'm speaking about immature eggs, we need to keep in mind that those follicles don't go through any type of stimulation. So we are working with really small follicles of 3 to 6 millimeter in diameter, or even smaller than 3 millimeters, which are not even seen at the ultrasound. So eggs from these really small follicles still have the potential to development, to mature in vitro, and then they can also have the potential to blastocyst formation. So I think all this experience in total made our work unique, and I was really happy to have this opportunity.
How many eggs would you typically obtain from an ovary?
It is the same as with IVF. It would totally depend on patient's characteristics, on their age, and on their AMH level. So we found that there is a direct correlation between the AMH level and the success of in vitro maturation program. We found out that if AMH is above 2, then the chances of a positive outcome is better. And then we found out that if the patient is younger than 37 years old, then also the chances for success for vitrifying blastocysts and vitrifying a good amount of M2 eggs is also much higher. So the principle is the same. If there are immature eggs, then we would retrieve it from the ovaries. We just need them to be there, which depends on patient's characteristics.
Would I be correct assuming that the smaller the follicle, the less likely it will have an egg which is able to mature?
Yes, that's absolutely right. We know that the more developed the follicle is, the higher potential the egg would have. And in general, if we just divide the follicles into two categories, the follicles which are larger than 6 millimeters would have a much higher potential. However, speaking about that, recent technologies which had been developed and introduced into the clinical practice helped us. For example, the biphasic IVM, about which we can speak later, helps to actually help the smaller follicles and these eggs from smaller follicles, and especially this biphasic IVM technology is beneficial for follicles smaller than 6 millimeters in diameter.
If you compare success rate, just a ballpark comparison, for follicles 6 and larger and smaller than 6, what would be expectation percentage-wise for maturation?
They have been a study on that from the Belgian group. So I think we can just refer our auditory to that, to read this paper from the Belgium group who compared different sizes of follicles. They have the exact numbers. But just out of top of my head, if we say, I would say that the potential of bigger follicles would be twice higher than the smaller ones.
How do you explain this?
So it just basic egg physiology. So in general, for the egg to mature, we need the communication and the nutrition of an egg from the somatic cells, from granulosa cells, and later from the cumulus cells. So the more advanced the follicle is, the more somatic cells we would have there, and the longer period of this communication by bilateral communication from the cumulus granulosa to the egg and back to the somatic cells we would have. So these really small follicles, they didn't have this long-term communication. They didn't get all the necessary molecules, and in general, there wasn't transition for mainly from the cytoplasm to mature in this follicle.
In vitro maturation exists for a long time. In
Yeah.
humans, it probably has a history which almost as long as IVF itself. Um, would you identify for us those milestones where there was major change, major improvement in probability of the egg mature in vitro?
You're totally correct, Dmitry, that the technology is really old, and actually, it's even older than our classical controlled ovarian stimulation. Robert Edwards was first working with IVM eggs, and only then there was a transition to our classical IVF. So the technology is very old, and the thing about it that it hasn't changed for years. So what has been done like in 60s, it continued to be done for years, and even now still the approach can be the same. That's one thing. And another important thing which I want to stress out, that when we speak about IVM, so many different things um, just combined under this umbrella term of IVM. So if we just go to PubMed and would type IVM, then we might get so many papers with different results, different approaches. And for someone who is not familiar with this technology, it can be really confusing, because very often IVM is meant, what is meant by IVM is just rescue IVM, which is not like the classical IVM. For example, if we have controlled ovarian stimulation and then we denude the eggs, get just denuded eggs, and we find out that they're just on the GV stage or M1 stage, not ready to be fertilized, then we can just leave them in our basic culture media, wait for several hours or overnight, then we get M2s, and then we can use them. And this is called rescue IVM, and we have this word IVM there, while it's not classical IVM. Then we have different approaches to AVM, and over this all these years, different approaches have been used. So one approach was to use the trigger. So we can have like several days of stimulation, then provide a trigger, then get a pool of eggs. Some of them would be mature, some of them won't, and then we would also culture them for maybe 20 hours or 24, denude them, and then fertilize. And then this data is reported. And when we look at this data, we don't know which of these eggs actually will mature from the beginning, while some of them matured afterwards. And the problem with that is that when we provide a trigger, the egg loses communication with the cumulus cells, and then the maturation wouldn't be efficient and wouldn't be complete. So I would refer to this technology more like mini IVF probably, or mini controlled ovarian stimulation rather than classical IVM. And then we have what I would call as a classical IVM, when we have no trigger. Ovarian stimulation can be minor, maybe 3 days of gonadotropins, or maybe there is no stimulation, but very importantly, we don't need the trigger because we want the communication between the cumulus cells and the eggs be preserved. So this technology for just using no trigger and retrieving the eggs have been with us for many years, for many decades. And many clinics are still using this technology. It's very great that recently, several years ago, ACRM published the committee opinion, which states that IVM is not considered experimental anymore. And they speak about this IVM to which I refer lately. So basically, this technology hasn't changed for decades, but it has proven that it can be safe and it can be efficient in terms that we can get pregnancies, and these pregnancies are healthy and without any abnormalities. And then at the same time, at the background, for many, many years, a lot of research has been done from basic scientists, and there were several groups in Canada, in the US, and a lot of efforts have been done in Belgium and in Australia. So these researchers have been developing the biphasic approach for IVM, and I think this approach has really changed the game and has really allowed us to improve the results of IVM and actually to compare these results to the controlled ovarian stimulation and to make this much more efficient. So basically, biphasic IVM is the approach when we allow when we prevent the asynchrony of the cytoplasm and the nucleus. And this asynchrony is believed to be the major factor which leads to the decreased results of in vitro maturation. Would you like me to speak more about biphasic IVM, or should we speak about something else? How do you want to proceed?
Yes, I would really like to dig deeper into what is asynchrony. To me, it sounds as a semantically meaningful thing, but I could never understand completely what is really this asynchrony is, how idea of asynchrony came into existence, and how delay in vitro maturation is explained to improve the outcome of in vitro maturation. I would really like to dig deeper into this.
So while in IVF, we just are really concentrated on an oocyte itself, and we think about the cumulus as something residual, which we just need to denude and get rid of it. In IVM, both the cumulus cells and the oocyte itself are very important. And basically, it is because the oocyte really depends on the cumulus cells for their energy source. So the oocyte itself cannot get and produce the energy on its own, and it depends on the cumulus cells for it. So once we give a follicular trigger, or we just retrieve an egg from the follicle, then their gap junctions between the oocyte and the cumulus cells, they become to break. And then actually the egg loses these connections with the cumulus cells. And then this distribution of the energy source to the egg get lost, and at the same time the meiosis resumes. So what we get in the egg in the end is that we get a mature M2 egg. We have the polybody, we might have the spindle, but at the same time, the cytoplasm didn't have an opportunity to reorganize and to physiologically mature because there were no such signals which properly was communicated for the cytoplasm to just cascade this process of rearrangement and maturation. And at the same time, it didn't get enough energy source, which would also allow it to physiologically mature. So this was a dilemma which the scientific community faced, that for IVM, we need to retrieve the cumulus oocyte complex. But at the same time, when we retrieve it, then we have the spontaneous activation of the meiosis and not enough time and also not enough cellular contacts for the cumulus to provide all the molecules which would allow the cytoplasm to mature physiologically. And that's when the idea of the biphasic IVM came. And the idea is based that we first need to prevent the cellular contacts between the cumulus cells and the oocyte. And then we also need to block meiosis just to have a stop and just to allow the cytoplasm to mature. And several inhibitors of meiosis have been tested, and like maybe you've heard of IBMX on them. Then there were some other which have been used, and one of the meiotic inhibitors which have been currently used more and more, and even clinically, is the C-neotropic peptide. And the C-neotropic peptide is actually the physiological peptide which is secreted by the cumulus cells, and it prevents the resumption of meiosis. And it has been also shown that when we add this meiosis blockage, then the cellular contacts, the gap junctions, are also preserved. So we can just block the meiosis for 1 day or a couple of days, and this time would allow the cytoplasm to gain more maturity and to arrange physiologically, because we know that even like the organelles distribution, the organelles structure needs to be different compared in the GV egg and the M2 egg. And this 1 or 2 day would allow the cytoplasm to mature. Then we can just wash out all the inhibitors, provide FSH and support for the nuclear maturation, and leave an egg for another day or two and allow it to mature then meiotically as well. And so in this way, we would have more synchrony of the cytoplasmic and meiotic maturation. And in the end, the research has shown that we get more competent eggs, which have much higher maturation rate. At the same time, they have much higher embryo development rate up to the blastocyst stage.
Let's assume that we have 3 days or 4 days, let's say 4 days of ovarian stimulation. Then we harvest these eggs from follicles without disturbing the connections between cumulus cells and egg. We block resumption of meiosis for how long? Let's say for day or 2 days.
Yep.
2 days? Your preference?
The research has shown that it doesn't matter, that starting from 22 hours, then it doesn't matter. If it's 22 or 48 hours, the outcome is the same.
Okay, so let's say for 1 day, for 24 hours. So we had 4 days plus 1 day. Now we have 5 days. 4 in vivo and 1 in vitro. We blocked meiosis. And then it improves in vitro maturation. My simplistic question is, why not just give it one more day in vivo with naturally blocked meiosis and just get these eggs after 5 days, so they have at the end the same number of days with blocked meiosis, what is the difference? There must be something else happening, not just number of not just the number of days. What would it be? Because we know that if we harvest eggs after 5 days, we'll have to still give them 1 day of in vitro blocking meiosis before they can mature. So what is the difference?
I think the main reason of us not having this long stimulation for the eggs is that just for the technical part, it's very hard to obtain immature eggs from larger follicles. So we know that the smaller the follicle is, the easier for the clinician it would be to obtain this actually eggs, which might sound not
Mhm,
so just intuitive. But the fact is that it's easier to obtain immature eggs from the follicles, for example, 5 millimeters compared to
mhm,
10 millimeters.
mhm,
And the technique of egg retrieval during the OPU for IVM is much different than the technique of egg retrieval during controlled ovarian stimulation. And again, it's based on the just the characteristics of the cumulus oocyte complexes. While during IVF, we have expanded cumulus and we have a complex which is just ready to be out of the follicle, and we can just have low pressure, and then the cumulus oocyte complex would be retrieved. With IVM, the technique is much different. The cumulus oocyte complex is very tight, is very small, and when we retrieve it, we don't use the pressure to obtain it, but the clinician has actually to cut it. And we can understand that the bigger the follicle is, the harder to cut it inside such a small cumulus oocyte complex would be. And the cumulus oocyte complex is very small as well. It would probably be around maybe 150 micrometers in diameter. So the cumulus cells are very tight, not expanded. So to get it from the large follicle of 10 millimeters would be very hard. So I think from the technological point of view, it has been just the standard to have 3 days of stimulation to get the follicles not more than 9 millimeters in diameter and then to retrieve them. I'm not sure if we get more days of stimulation, we might get more competent um, eggs, but at the same time, from the egg physiological point of view, without the trigger, there probably wouldn't be the signal of the cytoplasm to get mature. So while slowly the cytoplasm would be maturing while the follicle grows, I don't think that there would be a drastic change, the drastic signal for it to get this a maturation signal. So we might still need some in vitro time for even bigger follicles as well. And actually, that's what we see after controlled ovarian stimulation. We don't get 100% of mature eggs. Some of them are still immature, and we need some more time to mature. However, not many studies have been done on that, so I think it would be something interesting to explore in the future.
I'm curious that longer in vitro culture with blocked meiosis doesn't improve the outcome. And I'm curious because we know that physiological follicular phase duration clearly has an impact on egg quality. And even with ovarian stimulation, when it becomes too short, there is a cliff where if eggs retrieved, let's say, less than 10 days from the day one of the cycle, maybe 9 days, this range, the probability of an egg to be of a good quality, not necessarily matured, because they will mature, they will have polar body, but be competent, so they would be able to develop to blastocyst once fertilized, it does decrease with shortening of follicular phase. And this is very well-known physiology based on very large epidemiology, not only in IVF, but also in a natural cycle. And this is why I'm curious, why do you think extended block of in vitro maturation doesn't improve outcome if we retrieve eggs earlier?
We can still not compare IVM in vitro culture to the physiological follicle development. And in the IVM culture, we have like the essential molecules and essential components just to provide this basic maturation. However, in the follicles, there are so much more growth factors and interactions than in vitro culture. So I can just assume that what we have in vitro culture is essential to support development for one day. But then since the interactions and the composition is not as complex as in the follicle, then it might not be efficient to have this culture longer. But it would be interesting to see what the science would bring. There are now different approaches developing, and maybe with more components in the culture media or different approaches, like introducing some cells to the culture or maybe something else, then we would have more opportunities to provide better support and longer in vitro culture for the better egg quality in the end.
I think this would be very interesting indeed, to effectively recreate in vivo conditions in vitro. Would you agree with that?
Definitely, it has been a dream for many, many years, especially like in the follicle. Um, there has been some interesting studies in mice, and these studies are actually brilliant. So what they have showed was that if they take the follicle from younger mice and then they get the egg, GV egg from older mice, and then they have this amazing technique of actually putting the egg in the younger follicle, then they had much better potential for these older eggs in younger follicles, so which is brilliant. Of course, we have so many limitations for clinical use of this technology, but maybe it can be changed. Maybe the artificial follicle can be developed from stem cells or somehow from maybe artificial follicle by printing. Then I think this technology can also change our perception of egg in vitro culture, in vitro maturation, and might also give hope for older patients to have more competent eggs in the end. So I'm really excited to see what the future research would bring to us. And I think it's a really great direction to pursue.
Do you have any concerns, any reservations regarding the health in a very broad sense of children born after in vitro maturation?
Of classical AVM without any new technology used, we know that the children born after AVM are the same in terms of their somatic health, in terms of genetic and epigenetic status. So I don't have any worries about that. But of course, as the technology develops, all this new approach need to be really thoroughly tested, and the children needs to be monitored because there might be some epigenetic variations. Of course, the genetic status of the embryos and also the genetic health of the children is also a concern, because if the meiotic maturation occurs in vitro, then there might be some risks to it. I think there is a really big demand for the worldwide registry for the children born after IVM. Unfortunately, we don't have this registry right now, so it's really hard to track the results. And as I mentioned previously, when we speak about IVM, so many different approaches um, I just um, uh, I just thought about under this one umbrella of IVM. So it's really hard to differentiate which approach, which type of IVM results in which. In general, right now, we don't have any concerns. There have been no data which would raise any concerns in both classical IVM and biphasic IVM. But with the future technology, we'll definitely need more studies and in general to be really cautious about what we are doing and which impact it might have on the children born.
What has been the follow-up for children born after IVM? Was it just a birth, an evaluation at birth, or they looked at them when they would go to school, like at 6, 7 years? How long the follow-up has been? Do you know?
I haven't seen any studies about the long-term follow-up up to adulthood or like teenage years. I know that there were studies which followed children for several years, up to 3 years old, and they have shown uh, no differences compared to the children born after IVF. But once again, we can't control all the countries, all the data which has been accumulated. So there is definitely a need for the registry and for following up these children. And I think it would be a really great initiative to have this registry introduced.
Absolutely. No, I agree with this. And now when there are thousands of children born after IVM, um, I believe it is time to begin looking at their development benchmarks, not only at 3 years. At 3 years, I think it's too early because intellectual development would probably be better assessed. It's like 6, 7 years old. Uh,
Definitely.
and this
Then
is really,
puberty would be an interest to
uh,
see their reproductive status.
I would less worried actually about reproductive status than about like a brain development, because this is neurological features are some of the most sensitive to detect subtle problems. Uh, And I hope that somebody is going to invest uh, efforts and money into doing this research. It's not in itself, unfortunately, is going to make anybody famous. That's why maybe there's not a lot of people who take initiative, and it is expensive. So it has to be probably at the level of state, somebody to sponsor this kind of research. But I do think it's uh, it's important in part because I was always worried not only about in vitro maturation but also about IVF. We deal with very diverse population, and some deviations may not be clearly seen because we are so different. We just, okay, this child is just different. Um, uh, the reason I'm concerned is because Epic, you may know his experiments when he uh, in vitro matured from primordial follicles. It was very, very few publications. I don't even know if anybody reproduced his research, and he did observe some abnormalities, even though uh, the mice were born live, but they did have problems. Um, and when I spoken uh, uh, to Gabor Vayate, Dr. Gabor Vayate, recently, also he was kind enough to agree to the interview. He was without any reservation, saying that in inbred animals, when there is a established like benchmark, it's much easier to see any changes, any deviations from expectation when you have this uh, unified group of animals. He said without any doubts, he's seen impact of culture medium composition on uh, clear deviations from norm in this cows which he works with. So there must be some, or maybe some impact. I mean, maybe humans are more resilient, it's possible, but because we base all our IVF experience on animal studies, if we see something in animals, it probably warrants to look into IVF as well, because looking just as uh, just at live birth as a final measure of success may not be good enough.
I definitely agree. There are even publications for IVF that we know that different media can also result children health. I don't know like how universal these findings are and how we can extrapolate it to all the populations and all the clinics, but we know that there were some publications which stated that some types of media can result in children being large to their gestational age, for example. And with IVMs also, there are many media which has been used, different concentrations of hormones, different culture conditions. So it definitely can have an impact, and it would be really interesting to find it out. And I think now it's really a great time to do that because now we have the help of artificial intelligence, which can potentially take all these factors into account and maybe have the deeper analysis than the humans might have done it previously. So if we just accumulate this data and then have a great analysis of it, I think it's really important. Of course, we all like think about their promotion of science, of just getting ahead with our research for the benefit of the patients. And of course, it's very important to speed up our research and to have also the really healthy and holistic transition from the basic science to clinical research. But at the same time, we need to think like how safe it is to use it now. Do we need to do more studies? Do we need to be more cautious first? And I think we all need to ask these questions first before offering any of our technology to the clinical practice. And then even when we offer, we need to track it very carefully, also to be confident that what we do is very safe for the future children.
Right, or at least we'll be able to advise a female or a couple who come into IVF that there is a potential for this or for that, because they will probably take the chance.
Yeah, especially if a woman has ovarian cancer, there are no other options. So she would probably take a chance with in vitro maturation rather than just not having this opportunity at all.
What a percentage of blastocysts you would expect per collected immature egg in an average patient, if there is such a patient? Let's say it's a good prognosis patient. She is 35 years old, or maybe even younger. What would you expect? And you harvested, say, 50 matured eggs or 100. I don't know. Please tell us how many would you uh, obtain from a patient, and how many of them would become a blastocyst?
20% would be a good rate of blastocyst formation rate out of the retrieved eggs.
This is very impressive because it's just slightly less than average in ovarian stimulation cases.
Yeah, right now we are very lucky that the IVM technology, especially the biphasic one, developed to the stage where we can actually compare it to controlled ovarian stimulation. However, we always keep in mind that the efficiency can be lower. But if we take a younger patient, for example, with PCOS, then their chances of getting blastocysts and pregnancies with IVM are pretty high, and this technology can be recommended to them.
Do you think if we would develop better technique to retrieve eggs from the ovary without the trigger, uh, and we would be able to retrieve them not after 3 days or 4 days, but maybe after 10 days, do you think that this would be an improvement? Patient would have to be stimulated because if you don't give patient a drug, she would end up by day 10 with only one follicle. So it would have to be some type of stimulation to get eggs before the trigger and then but then we don't have benefit of, I guess, of IVM, because now you have to give a medication to the patient, and it kind of defeats the purpose. So it's probably not just, as I'm thinking about it, it's not just um, the technique for retrieval. It's also uh, you have to get these eggs very early, because otherwise there is no benefit of not having ovarian stimulation, and this is what you're trying to achieve.
So, if we speak about the efficiency of egg retrieval, it really depends on the clinician's expertise. So, the more cases they had, the more practice they had, then they would be more efficient, more quick, and their higher amount of eggs they would retrieve from the follicles. So, usually the clinician who is experienced, then they would get around 80% of eggs from the retrieved follicles. While if someone just starts practicing IVM, they might face that they get only 50% of eggs out of the retrieved follicles. So the more the practice, the better clinicians become. And it's this, like, it works with everything what we do. The more we do it, the more proficient we are. So just my recommendation for the clinicians is to get really great training from someone experienced, and then also to have an opportunity to practice it. The best patients to start with would be patients with PCOS, because they have more follicles, and then they have opportunities to have several attempts of their IVM programs. While if we speak about, for example, oncofertility patients, they might have only one chance of egg retrieval, and they might have a smaller number of follicles. If we speak about the day of the cycle, there have been a belief that IVM can be done on any day of the cycle. However, I want to tell everyone to be cautious to perform IVM around ovulation, if the patient has an ovulation, because we know that the dominant follicle can actually lead to atresia of other follicles. So in the end, we might just end with degenerated eggs, or we might end with the egg which is already spontaneously mature, and then in general the maturation rate and the blastocyst formation rate, which would be much lower. So I would say if you take probably ovulation and 3 days before and 3 days after out, then all the other days would be okay. But if we have an opportunity to start in the beginning of the follicular phase, or in the beginning of the luteal phase, then it might be a good option when the follicles are small and they're even. The recent research done in Vietnam has shown that with biphasic IVM, if we have 3 days of stimulation or no stimulation at all, it doesn't impact the outcomes. So there might be no stimulation used at all, and it's a good option. And then we should think like, what is the patient with whom we are working? If there is a PCOS patient, they might not have a cycle at all, then it wouldn't be a problem at all. If it's a patient with a regular cycle, then we can also think what is the reason for them going through IVM. If it's oncofertility, then we can just go ahead, maybe the next day with the IVM, just try omitting the time around ovulation. Or if it's a patient with more complex conditions, then we can have the more complex evaluation of their status. If we have an opportunity, then we can start maybe with day two of the cycle and see how it's best to proceed afterwards.
Well, I guess it makes sense, because oftentimes stimulation not even started until day 3.
Yeah.
So if you harass them on day 3, you can as well just avoid stimulation completely.
Definitely. So, one of the benefits of IVM is just not to have stimulation. It has been introduced widely to prevent hyperstimulation, which is not so much a risk anymore in current practice. But in general, there are zero chances of hyperstimulation with IVM. So that's its main benefit. And another thing is that many patients might be a little bit not comfortable with drug administration. Then in some countries, medication can be really expensive. In this term, IVM offers benefits. It can be cheaper in some countries, and then it can allow patients not to have any medication and to have the treatment quicker and to have to allow more urgent treatment for many patients.
Do you think that there's a chance in vitro maturation can be offered, expanded, I guess, into patients who are not PCOS, not cancer patients, just to pretty much all patients?
It would really depend on the advancement of our technologies. So right now we know that with a standard patient, IVM would still have lower results than classical controlled ovarian stimulation. So if the technology develops further and it would be of the same efficiency of controlled ovarian stimulation, then I think it has a really great chance of replacing controlled ovarian stimulation. For example, if we even refer to science or just farming, like no one does controlled ovarian stimulation on cows, for example, or on sheep, horses. Everyone just use IVM because it's cheaper, it's easier, it's more just easier to handle. And That's how it's used worldwide. If you know that that IVM is also quite efficient for all groups of patients, and that's what we need to study in the future, then I think it has a really great chance of dominating our reproductive field. But even now, it can be a great option for patients with PCOS, for patients who need oncofertility treatment. This is the only option with patients with with resistant ovarian syndrome. And it would be really interesting to see how indications expand in the future. But once again, the technology definitely has its benefits. It's quicker, it's more patient-friendly, and I think more and more patients in general get more interested in this technology.
Now, I guess my last question about this will be, what is cooking? Like, what is happening in vitro maturation? Where it's going? Do you see any major um, changes similar to introduction of synchronization of nuclear and cytoplasmic maturation?
Think where we are going and where should we focus is to improve AVM so it would allow to decrease the aneuploidies in the eggs. So we know that some of their meiotic aberrations happen during the final maturation. So IVM has this really great benefit that we are working with GVs which haven't completed their meiotic maturation. So if we can develop the technology which would help to decrease the number of aneuploidies, then I think it would be the best achievement of this technology. Then we can offer it to the patients of older age who for whom we know that the number of eggs with the correct genetic status is so low that sometimes it's just easier for them not to go through IVF, even when they have a higher ovarian reserve, and then to use other options such as donations and so on. So if the technology is developed which would allow to decrease this aneuploidies, then it would be this major achievement. There are several ways to do that. One of the way to explore it is, for example, to use antioxidants. And this approach just to decrease the antioxidant stress to the egg. And there have been some works done on the animal models which have shown that utilization of different antioxidants can help with improving egg quality and to improve the genetic status of the eggs. I have published it in Cells, and there is a big overview of different approaches to that. Another approach would be to create the artificial surrounding of like maybe artificial follicle, which would allow also for the egg to physiologically mature. And as I mentioned previously, the surrounded as often a younger follicle might be a good solution, but then we need to think how we can use autologous cells to allow this really healthy oocyte maturation to occur. There is some research done on stem cells, which differentiates stem cells to mimic granulosa cells and to support these eggs for maturation. So maybe this would be a good approach. Maybe something else would be created. The bioprinting technology, bioengineering technologies are now developing really fast. So I have high hopes for that. Or maybe we'll have this bioprinted follicle in the future, which would allow the eggs to mature. And yeah, I think it would be it's a really nice and interesting field of reproductive technology, and I am so happy that a lot of effort now is put into this technology, and more centers that start to pay attention into it. We don't know, maybe different technologies can be combined. If I just dream and take away all the ethical and legal consideration, we can think of even combining IVM with cytoplasmic replacement therapy. Maybe on the GV stage, we can do the cytoplasmic replacement for the maternal GV and to replace it into the donor cytoplasm and then mature it in vitro. Maybe this would also help us to have the healthier and more and an egg with a higher potential. We don't know the technology, and the thing which we need to take into consideration that the technology develops much faster than our legal system and then the ethical approval for all of these technologies. And of course, it makes sense, as we spoke previously, the health of the children born is our main concern and is the thing which we need to think about. But it's great that the technology is developing so fast and many approaches can be used. And I hope that we'll see in the future which one would be the most efficient one.
Well, Anastasia, thank you so much for this very interesting conversation, and good luck with your efforts in creating more and better in vitro matured eggs.
So much, Dmitry. It was really a pleasure speaking to you, and thank you once again for inviting me.
Thank you. Bye-bye.